Good afternoon. Thanks for joining us today. My name is David Kendrick. I'm a physician. I practice internal medicine and pediatrics. I chair the Department of Medical Informatics here at the OU School of Community Medicine. And for the context of this presentation, I'm also the CEO of Oklahoma's nonprofit health information exchange called My Health Access Network. Over the last few weeks, I've been getting lots of questions from the media, but also policymakers and others about our current COVID-19 status, and in particular how the masking ordinances that a number of our communities in Oklahoma have passed, how those are affecting the outbreak, the pandemic, and what the results of those might be. So we convened this meeting today to maybe discuss and answer some of those questions and others you may raise. We again appreciate you joining us. I thought first I'd give you a little bit of background on My Health, what My Health is, what kind of data it has, how does it differ from the state health department's data and reporting, so that you can have the context you need to understand or to interpret the numbers I'm giving you. So My Health Access Network is a health information exchange, and in Oklahoma this is the nonprofit organization called My Health for short. And we connect, the My Health organization was founded by the doctors, the hospitals, the clinics, the pharmacies, the optometrists, long-term care, a full range of healthcare providers across the state, as well as participating state agencies, to exchange health information securely so that when patients get care somewhere away from their primary care office, that their records are available, say in the emergency room or in the hospital. And there are a lot of other uses for this network so that patients can be confident that their record's going to follow them wherever they need to go. In the course of this pandemic, of course, other really important uses for health information have arisen. And in the early days of this pandemic, say in the February-March timeframe, people began running lab tests for COVID-19, and those lab tests were coming across in the data feed into patients' records, but they were not interpretable because they were brand new, they had new labels and so on. And so My Health's job was to clean up those results and deliver them to the patient's doctors. And in the course of that, we've also been asked by several parties, including the members of My Health, the hospitals and the clinics, to help them think through and make decisions about what to do with things like reopening and masking policies and other things, and also to help out the state with some of those some guidance on that front as well. So the differences between what's in My Health and what's in the state health department are that My Health Connects has live data feed connections from hospitals and clinics and many of the other organizations. So usually within about a minute of a test result being completed, that result goes into the patient's record in My Health. And this is really important because on the public health side, that reporting can take hours and even days to get into a standard process that flows into the state health department systems. And so that means that the data can be more timely in the health information exchange, but it also means that the data in My Health is limited to the data coming from the healthcare delivery system. So when there are situations, for example, where an employer does testing, or a university does testing and they use an outside system, those results may only go to the state health department. And in particular, we know, I think from lots of discussion in the press, the health department definitely gets the detailed information on all the positive tests, meaning the name, address, phone number, where people live, and so on, but in many cases only gets the counts of negative tests. And so that creates a situation where it's possible to know the absolute count of positive cases in any given part of the state, but it's difficult to know what % of tests are positive, right? And we'll talk more about that in just a moment. So the other difference, of course, with the data in My Health is, as I was saying a moment ago, is it's not as complete as what the state has on the positives, because there's a law that says all positive tests must go to the state. So there are a few important gaps, and I would estimate that My Health has generally between 60 and 70% of all test results in Oklahoma. So it's a pretty good approximation, but not complete, so take that into account with the numbers I'm reporting. On the other hand, as I was saying, it is a bit more timely, tends to be, and also the identity of the patients are resolved, so that if a patient gets multiple tests, multiple locations, then those are all tied to the same person, so that it's rather than just counting tests, MyHealth is able to report on unique individuals that have been positive or negative or both in some cases. And the state does that to a degree as well, and they can explain that in more detail the way they do that. But certainly that's one of the strengths of health information exchanges, being a part of the public health delivery system by having this more live flowing data. Certainly less effort on the part of hospitals and clinics to report these results because they come out automatically and electronically. And if you've been following the discussions with the hospitals and others, there's a lot of labor involved in tracking beds and reporting those and tracking PPE and reporting that. And so anything that we can do at MyHealth to reduce the burden on the healthcare delivery system, which, by the way, is trying to deliver healthcare and trying to deal with this crisis, to reduce the reporting burden is definitely a goal by having these sort of more intelligent connections and systems. So that's MyHealth. That's the data and how it's different from the data that the state health department has. I think the two data sets complement one another in some very important ways. And so the question had come up, especially in the last few months in Oklahoma in particular. City councils, mayors have been considering masking ordinances, and those would require the use of masks. They're all a little bit different from one another, but in general require the use of masks in public places, in stores and other places. And in most communities, those have been hotly debated policies in city councils. And so MyHealth has been called upon to provide data for those community level discussions, and the board of MyHealth has agreed that that's an important use of the data, and in fact just last week voted to enable the MyHealth data to be used in this way. So it's an important contribution everyone felt to the public health response. So as these policies have rolled out, you may be aware, but they've sort of each community has had a different date that's the effective date for their policy. And so we began looking at the medical literature to see, is there evidence already published beyond Oklahoma on a national level? And just this month in Health Affairs, Lou and Wehby, W-E-H-B-Y, and L-Y-U are the authors in Health Affairs, the August edition. They published a study that was a national study comparing states with mandatory masking policies with states without mandatory masking policies. And what they did is they looked at how long after the masking policy went into effect were changes detected in case counts. Okay? And so at approximately the 7-day time window, case counts had dropped by 1.1%, daily case counts, by the 14-day window by 1.4%, and by the 21-day window by 2%. So definitely showing an effect across a broad swath of states with a broad swath of specific policies, but all pointing to masking in public places. And so then the question becomes, if this evidence is now out there, how does that translate to Oklahoma now that we've got sort of our own laboratory where some major cities have opted into having a mandatory masking policy and the rest of the state has not? Can we look at the data and decide or draw any conclusions about whether the masking policies might be having an effect? And that seems to be the question I've been getting. So the analysis that we've been able to do, and we've been tracking this really from the first moment of the first policy going into effect in Oklahoma. I have to thank our friends at the State Medical Association, Oklahoma State Medical Association, for tracking all of the different ordinances and making sure that the start dates are clear and so on, so that we could use that in this analysis. And what we were able to show, what we're able to do is to do basically a case control assessment, meaning, in this case, the cities with mask ordinances compared to the cities without masking ordinances across Oklahoma for the same period of time. Does that make sense? And so in doing that, we were able to look at it, but we use a different metric in MyHealth because, as I said, we don't have 100% of all the lab results. So it wouldn't be quite as accurate to say, the case count went up or down because we might be missing a test from a university, for example, or a public health department that doesn't share data with MyHealth. So what we use is the positivity score, or the rate of positive testing. And that's a metric that's a little bit different, but it's a little less sensitive to reduction in testing. So as you probably know and have heard famously in the national press, one way to reduce positive cases is just not to do as much testing, right? And so, some have said that using case counts alone is susceptible to reduced testing rates, to just reducing testing or the unavailability of tests in a community. And so the way that we use this positivity rate, which basically says, okay, well, if there were only 100 tests available, what % of them were positive, right? So that we can get a directional sense of, is this outbreak everybody in the community that was sampled, or is it just a small percentage of people in the community that were sampled? That metric itself is not perfect, but as I'm sure everyone's learning in this pandemic, learning which numbers to trust and in which situations is half the game, right? So positivity is a very useful metric when you are not confident that everybody in the community is able to be tested, which I think is the situation we're in here in Oklahoma. And certainly one of the things that MyHealth tracks very carefully is the average testing turnaround time. And I would note that over the last 4 or 5 weeks, testing delays grew exorbitantly. And so some of the tests, sometimes the average turnaround time for all the labs that feed data to MyHealth would exceed 100 hours on average for the week. But I'm happy to say that this last week we got to our lowest ever, which was a 22-hour turnaround on average for all the tests coming into MyHealth. So that's a good sign that our infrastructure is improving and that we're going to be able to meet the needs here. So back to the positivity metric and what's happening there. So when the way MyHealth does this is we track a 7-day moving average of the positivity score, similar to what you may have seen as the 7-day moving average of case counts. We do that for the positivity score, which again is a percentage from 0 to 100. Typically the positivity score, most folks in public health say that above 10% is bad in a positivity score. Below 5% is a good level at which, if you've got a couple weeks at below 5%, then you're in fairly good shape as a community. And so MyHealth every day, in fact every hour, refreshes our dashboard on positivity scores, and we track that over time. And so in this particular analysis of the effect of masking, what we did is we treated all cities without a masking ordinance as the control group and monitored the change in their positivity score as a 7-day moving average of positivity over time, beginning with the first day of the policy that went into place for those different cities that do have an ordinance. And then we compared those to the changes in positivity over that same time window for the cities that do have an ordinance. So what I have for results here then are in looking at the first 7 days after, and as I said a moment ago, each city turned on their policy on a different day. So we used the day Oklahoma City began, and the day Tulsa began, and the day Norman began, and so on, and counted 7 days forward from that day to do this comparison. So in the first 7 days, the positivity rate dropped by 0.47%. Okay? By the 14-day window, it had dropped. It was a negative 7.57%. And by 21 days, it had come up just a bit, but was still lower at 5.73%. So that is, again, comparing the cities without a masking policy to those with a masking ordinance. And the total number of people considered in the cities with a masking ordinance was 1.3 million people in Oklahoma, and the cities without a masking ordinance was 2.7 million, the balance. So I'll pause there and take any questions.
So you may have covered some of this already, so feel free to skip over these. But some of our questions are, how is this data different than the OSDH data?
So as I was saying a moment ago, the OSDH data is gathered under a public health mandate, and so all positive tests are required to be reported. by name and all the details of the patient's case so that they can be contacted and they can get case management and so on. The negative cases, on the other hand, are not necessarily, often the counts are reported, but not necessarily all the details of where the patient lives and so on. So that makes it difficult to report a positivity rate at any level other than the statewide level from public health data. On the other hand, health information exchanges have they have a proportional number of positives and negatives and all the details behind the tests to be able to identify, one, is this a person who's, where does this individual with a negative test live, so they can be calculated in the right county or zip code, but also so that we can tell if it's the same person or not, getting the test again. And so those are two important differences. I would say, I believe the Oklahoma State Department of Health is doing what's called identity resolution to try and tie tests to the same person if they've had a test multiple times, but it's difficult to do. It's really a core service of what health information exchanges do.
Perfect. So two of the questions that we've gotten a lot are, do mask mandates work, and are mask policies effective in Oklahoma?
Well, that's the root cause for this conversation today. What I would say is, based on the national literature, the Health Affairs article I referenced, which considers a broader, more national picture, which does indicate a reduction in case counts after masking policies are implemented. And at least this early look at the data from MyHealth, which also seems to indicate that at least the positivity rate is declining in cities that have a policy compared to those that don't. And here's something to keep in mind. Just having a policy doesn't mean that everybody adheres to it, right? Just having a policy doesn't mean that anybody in town is going to wear the mask or not. So we are intentionally just comparing straight up communities with a policy to those without a policy. Undoubtedly, more effect could be achieved if there were higher compliance with a policy. And I would also say that that's a knife that cuts the other direction as well. There's often masking that begins in communities just when it's being talked about, right? So even before it's a policy or a requirement, it's a recommendation. Certainly, our state health department has been at the forefront of recommending that masks be worn. So there's definitely that in the background as well.
Perfect. What do you think the next step is for our state in terms of masking?
Well, we're entering into a very interesting phase, and that is as universities open, as schools open, we'll have a whole new category of potential exposures going on throughout the summer. We started, let's say, back in March, and we did a hard close and really jumped on top of this issue. And then as we began to reopen, at the same time, schools were letting out. So schools mostly, as far as I know, didn't return. And so we've had 4 months now without the impact of primary, secondary, and university education on the possibility of transmission. Even in that window, though, we've seen some events that we might be able to look at as potential indicators of what we're going to experience now. For example, we've had some outbreaks around funerals held in outdoor settings. We've had outbreaks. Certainly, one of the pieces of data that MyHealth saw most prominently was the Memorial Day weekend bump, and an enormous jump in the rate of positive cases in the week or so following Memorial Day among 20-somethings, sort of teenagers and 20-somethings. And then over the course of time since then, so through July and now into August, we've seen that rise sort of be shared across the older age groups. And I think we've discussed most recently how hospitalizations bumped up. They've come back down now, but hospitalizations bumped up as older folks began to get those infections. So I think we have to look at the situation we're entering into now as schools are opening and give it a good hard look. I mean, we're already seeing, University of North Carolina opened and closed, opened and went to remote classes. I just dropped my kids off this morning at school with a mask on, and I'm very hopeful that they're going to be able to stay together with their schoolmates and their teachers. But at the same time, and I've certainly given this advice to schools, it seems that almost every lesson plan needs to be both on-site and remote, because it's going to need to be versatile in the short term. So I think Masks are an important component of our response as a society and as a state. And I think they're with us for a while. You know, the metric of can you get your positivity rate below 5% for the duration of an infection, meaning about 2 weeks, is a reasonable thing to look at. But we obviously need to be watching the data carefully.
Perfect. We just had a couple questions come in. So how hard is it to track effectiveness in a city like Tulsa, where some people work in Tulsa but live in Broken Arrow or Wausau, where masks aren't required?
That's a great question, and I've actually been able to, for some of the city councils, been able to slice the data down to the suburbs of Tulsa and compare suburbs to Tulsa. I don't have the numbers in front of me right now, but we also see a difference between closed cities that have different policies still have been showing a difference historically. I don't know where they are today. And that's something I should make sure you all understand about this data. It is living data, right? Every hour we get new updates. And a single outbreak, a major outbreak in a site of employment or a funeral or a school can greatly change things in the way a community looks. This virus is not air pollution or a storm that affects a broad swath of people. It really affects people who are in contact with one another, and it makes it really difficult to say anything. It's almost really not accurate to say anything about the state as a whole because this outbreak happens at such a small level with individuals and communities and grows from there. So having the ability to slice the data down to zip code and even smaller is really the way, I think, to track and study this.
Perfect. We had a question from Carmen at the Oklahoman. Any guesses why the rate ticked up slightly between 14 days after mask mandates took place and 21 days afterward?
I would say that that's one of those things that has to do with specific outbreaks. One of the communities with a masking mandate has not had the same effect as the others, and I'm not prepared to discuss that community yet because we're trying to get to the bottom of why. But that was largely driving that bump up. I think you have to understand also that even though I did tie, and this is a little bit wonky on the data side, I'm sorry, but even though I did count forward from the date that the policy went into place by 7 days and 14 and 21 days, several of those overlapped one another, meaning there were a cluster of policies that went into place sort of mid-June, and it just so happens that the whole state had a big bump at the end of June and early August, if you guys will recall. And that big bump is part of what you're seeing in that reduction. So, the thing with big data like this is you've got to figure out how to sort out the confounders in it, and so anybody in my position will always tell you we'll know more with more data and a little more time. So.
Steve with the Journal Record asked, do you feel that mask policies would make it faster and easier for the economy to rebound?
Well, that's a great question. I think that depends on what metrics you want to use for defining the economy rebounding and broad reopening. I think this is a cost-benefit analysis around masking. Certainly, there are basically three positions here. One position would be do nothing, wait on herd immunity. Another position would be lock down and have no commerce at all. And the middle position, which I think a lot of communities have steered down, is let's do masking and allow commerce to continue and hope that reduces spread enough that we don't have to go to the extreme closed down event. And so I think in that sense, this is a relatively low cost and potentially high benefit intervention. And I'm saying that now not as a representative of my health, but as a physician. I think most of my colleagues would agree with me. I mean, we wear masks not necessarily to protect ourselves. We wear masks to protect others. And that's one of the things I think is great about living in Oklahoma is that neighbors care for one another, and so this is a policy where people get to demonstrate that.
What would it mean for a city or the state if we were able to get the positivity rate
Well, I think it would mean we could be confident that we're on an improvement trend, and if we could tie that result to specific actions that we took, then we could see ourselves as national leaders in addressing this outbreak, this pandemic. Certainly, there are countries around the world where they've had success that we've not yet seen in this country, and there's some lessons there. But I also think there's a hefty amount of innovation we can do here in our own state to demonstrate that indeed we can lead in this pandemic and not just wait on others to tell us what the policies need to be or the interventions need to be, but we can actually take the lead.
Do you have any data about different types of masks, like cloth versus disposable single use, or is any mask usage in general?
Well, there are certainly differences in masks, and this is not data that MyHealth has, of course. This would be based on what's in the published literature. I think my colleague, Dr. Bratzler, has spoken on this before at length, but basically, masks go all the way from the N95 down to the barest cloth you might put over your face. And I think the one element, I mean, obviously the mask I'm wearing, which is a surgical mask, is a little better than just a cotton cloth mask. But at the end of the day, anything that can, remember this is to protect you from my germs, anything that will capture the droplets of water and mist that come from my mouth and nose as I'm speaking is going to be protective of the folks around me. So it's like, these are not actual numbers, but this is a sort of a guesstimate that there's something like 90% of the benefit to wearing anything at all, and 95% of the benefit to wearing a better mask, and 99% to wearing a perfect mask, right? So let's get 90% of the benefit and get everybody masked. I think the other piece of news that's come out recently that I haven't studied in detail, but I'm sure folks are aware of, is that neck gaiters may or may not be sufficient, which is the wrap around the neck and up onto the face. And I see a number of people wearing those. I'd say they're better than nothing, but it may be the case, and I'm not sure why I'd wear that in August in Oklahoma, but it may be the case that just a plain face mask is better.
And the anti-mask group is suing the city of Tulsa over its mask requirement. Are there any health risks to wearing a mask as they claim?
I've not been convinced of any health risks to wearing a mask. In fact, the people who would have the highest risk, who would be most likely to complain about shortness of breath or inability to get oxygen or the other things I hear anti-masking campaigns complain about, those are the very patients most at risk, because they have asthma, because they have chronic obstructive pulmonary disease, because they have conditions that make it uncomfortable to breathe. In some cases, they're most likely to have a bad outcome from this virus.
Would we see a bigger drop in cases if regionally there were mask mandates as opposed to some cities doing it and their neighboring city doesn't have a mask mandate?
Well, that's a great epidemiology question, and it has to do, of course, with how much community interdigitation is there between the different communities. But certainly it stands to reason that if one individual can come from the community next door and undo all the masking happening in a particular store, then you would expect that that neighboring policies would be more helpful.
Carmen from the Oklahoman had a follow-up question for you. So
Sure.
eventually, if some local mask mandates will expire or they'll have to be extended, would you recommend that these ordinances be extended?
I think it's about time that we as a state or each community pick a specific target for when is the appropriate time based on data and not emotion or whatever's currently hot in the news, but an actual data point to decide when to rescind a masking policy. And obviously everything is subject to to new evidence coming along, but I mentioned one possible metric, positivity below 5% for a couple weeks could be an indicator. There could be others, but then at least you could remove some of the politics from the discussion. And honestly, I like the sort of setting of a goal as an incentive for a whole community to get behind that goal, right? we can get back to normal when we've got our rates this low. Let's all get behind this, and heck, let's have some competitions between cities to see who can get there first. I mean, I think we've thought about doing that kind of thing for diabetes, for obesity, for other conditions. This is the clear and present danger right now, is this pandemic. So to the extent that we can gamify or get folks behind, trying to achieve a specific target rather than this sort of fluffy, whatever the city council decides at some point based on the debate, I think that's going to be a positive.
So what are your thoughts on how long masking mandates need to be in place?
Well, as I say, I'd set a measurable target and follow that. And certainly My Health has already supplied several different city councils with follow-up data over time on their own communities, and are happy to continue to do that if folks are interested.
Corey from the Tulsa World had a question. We'd like to hear your thoughts on the strengths and weaknesses of Tulsa's mask ordinance and whether you would recommend any alterations or improvements to it.
That's a great question, and it's pretty detailed. I have to admit I don't have all the details of that ordinance in front of me. I remember the debate and was involved in providing data during that conversation, but it's been several city councils ago. And so what I think I recall is that there is a lower age limit for the policy. Certainly my children don't technically have to wear masks in some stores. And yet at the same time, as they're returning to school, they are being expected to wear masks at school. So that might be a gap in the policy that could be addressed. School-age kids, I think maybe in the debate, I can't get inside the heads of the counselors, but I suspect there was concern that kids may not tolerate a mask well or be able to wear it, and I think they're now learning to wear masks, and in fact learning how to learn while wearing a mask. So that might be something to consider. We all know that children are at much lower risk. I mean, somebody in their teens and 20s has only a tenth of the chance of being admitted to the hospital as somebody in their 70s and 80s. And it's really, once somebody has been, had severe enough symptoms to be admitted to the hospital, that things get really serious in the outcome side. So we know that kids are not nearly as susceptible to bad outcomes in this disease, but their teachers are. And we might be throwing the proverbial baby out with the bathwater if we are in schools, and yeah, maybe some kids get it, they go home, they're fine, but the teachers get it, and now we don't even have anyone to do remote learning, right? And not to mention the fact that the teachers can be at higher risk for some of these bad effects by being adults. So
this question goes along with what you just mentioned, but Robbie from State Impact wanted to know why mask mandates are a valuable tool in K-12 schools.
Well, I think, there's definitely need to do something. Everybody feels the need that we're in a different time today, and we've got to have some policies. And there's also a strong emphasis, American Academy of Pediatrics on board with this as well, strong emphasis on getting the kids back to school and having them in school, because there are lots of, there's the education itself, there's a socialization, learning to work with their peers and, growing towards being productive adults. But at the same time, the schools often are the services that kids have, access to meals, childcare, daycare is often associated with schools. So it is a critically important part of this fabric of our society to have kids in schools. And just like, the discussion around, we can't afford to have all of our commerce shut down and everybody be at home in quarantine, and masks provide a viable middle road there, which is sort of a low-cost, high-potential impact intervention that can allow us to stay open. I would say the same thing with schools. Masks make it, a more viable option to have kids together in a schoolroom setting, classroom setting.
Perfect. Our last question is from Maureen at KTUL, and she wanted to know what your initial reaction was when you saw the data.
I wasn't necessarily surprised. I have had the benefit of doing reviews of this data really since the very first COVID-19 case came in back in March, and I had my suspicions. My biggest question was whether the data would show any effect anytime soon, right? And I will tell you that what I am showing in data is an observation based on a comparison between two groups of communities. There are lots of confounders in that, but by taking communities that both have the same number of confounders, presumably, right? They both have funerals outdoors, they both have public setting events and so on. Those communities then I think that we've made this a more valid analysis. So I guess my initial reaction was, okay, that confirms what we thought might be the case, and so I think it's. But I would say probably a lot of people would be surprised by these results.
We just had one more come in. Have you mentioned how many communities are in Oklahoma that have mask mandates?
So there are, let's see, I've got a list here. The list I've been working from has 1, 2, 3, 4, 5, 6, 7, 8, 10, 11 that are maybe 12 that are active. The challenge is that some of the communities are within other communities, right? So like War Acres and the Village in Oklahoma City, they're considered in the Oklahoma City numbers. So I basically have broken this out, and then some, of course, have a mask mandate, but it doesn't go into effect until later in August or until September. So the ones we considered were the major cities everybody's aware of, and 1, 2, 3, 4, 5. So 1, 2, 6 cities were considered in that.
Okay. We just had one more for the journal record. Are we safe to say that 3 weeks after a mask mandate is implemented, 5.73 people out of 100 in that community would have been spared from contracting COVID?
That's a tougher leap to make. What I can say is that if you randomly sampled 100 people in that community and tested them, that the rate would be lower about 5.3% lower in a community with masking than in a community without masking. It's difficult to extend that to the whole population because, again, positivity is a sampling method. It's a rate based on a sample of the community and not necessarily the community as a whole, because I don't want to get too wonkish on this, but people who don't get tested don't get tested for a number of reasons, right? They have no symptoms. They don't have transportation to get to a testing center. They don't have resources. Maybe they're not a citizen. They fear seeking health care. So there are a lot of reasons that we can't say whole population, but that we can say if you were to take 100 people, this is what we would expect.
Wonderful. Thank you, Dr. Kendrick.
You're welcome. Thank you.